Welcome to AARP, Arizona Hispanic Connection. Educate. Celebrate. Connect. Arizona Hispanic Connection.
Good morning. Good morning. This is David Parra, and the program is Opioids Killing More Than Pain Today. This is the subject. This is AARP, Arizona Hispanic Connection. This is a very, very important subject. I'm not as familiar, I have to admit, with this subject as I have been with others, and I have had to spend a lot of time in conversations with several of our guests just to kind of get a handle of this issue. But to be very frank with you, I got scared. It really scared me. I think it's an epidemic. It's being called an epidemic, an emergency. This issue of opioids is hitting the country very, very hard. There's a lot of people dying. So this is the subject today. We have several guests. We have Felipe Gonzalez Castro from ASU, and we'll have a chance to start the conversation in just a bit. Then we also have on the phone Nick Vasquez. He's a medical doctor. Felipe Gonzalez Castro. Felipe, you have a lot of things in your bio that I would spend a long time reading it. But you are a scholar. You have a PhD, and you have a master's in social work. Correct?
That's correct. Yeah.
Yeah.
And my PhD is in clinical psychology.
Okay. And just very briefly, if you can tell us what you do currently at your current position at ASU.
Sure. I'm currently in the College of Nursing and Health Innovation, and we have a center on health promotion and disease prevention. So I'm taking an active role there in working with various projects, including my own. We really do try to be active in the community, which is another important feature of what certain professors do, and certainly I take that very seriously. So what we try to do is really work with community and to try to provide positive experiences, in my case, promoting health in the community.
Nick, thank you so much for joining our program. Good morning, and welcome to our show.
Thank you.
Thank you. And we are also joined by Representative Tony Navarrete. He just walked in. Thank you for coming. I know you're busy, and I really appreciate you making time to be with us today.
Yeah, well, we're very happy to be here and very looking forward to all the questions that we have today.
Perfect. I confess to my guests that this is an issue that I have almost no knowledge about. And when you put together a show, you are required to learn at least a little bit so that you can direct the conversation and then give segue for your experts to really present the information. But I really trust that our expert will do a great job, as they always do. And let me pose this question, because I don't want to go to the issue right now, the problem, because opioids is a crisis. Opioids is an epidemic. It's killing thousands of people. I really got shocked just in the little bit of research that I did this week about this problem. Cronkite News, on their website, they have a video that they made that I'm going to ask everyone to help us recommend that video, because I believe it's like a 30-minute video, an unbelievable video that I believe everyone should watch. I'm going to ask my family if we can watch it as a family. It is just amazing. But let us address this issue. We have 60 minutes to do this. Let's talk about the history of pain control, of medications, on the positive side, because I assume the doctors right now are having, are seeing like the bad guys, are they prescribing too much, this and that, and we're going to get to all those issues. But how did the industry or the science evolve in terms of producing medications to help people to manage pain? If we can come to you, Felipe, and then we go to Nick, and then we'll continue. Go ahead.
Well, let me contextualize. Pain is an interesting experience because those that have it will report that they are hurting, and we definitely believe it. But many times, the level of pain reported and the extent of tissue injury don't correlate too highly, although there is something wrong with the body, because pain is the body's natural signal. Something is wrong. Fix it. Do something about it. Now, there is acute pain where you cut yourself and you have pain and it begins to heal, so that goes away, and so you don't have to take too much in terms of medication. The big issue is chronic pain, where there is a permanent injury in the central nervous system or to soft tissue, and those are injuries that may heal but not entirely. So you have the transmission of nerve impulses that register in the brain as pain ongoing, and some of that does not stop. So that's where medications come in that block the transmission, and that is a real gift from God,
Right.
And people that the early folks that identified something in the poppy plant and they found that it helped them felt it was a gift from the gods. So it is a wonderful thing, but the problem is that conditions, the way I look at it, addiction begins as a social process and then continues as a biological, neurological process. Several things go together, and the thing is, there's a change with medication, with any legal drug, but also legal medications. There are changes in the central nervous system, specifically in terms of heroin, for example. The dopamine system, which is a reward system in the midbrain, in the mesolimbic area of the brain, that is now seen as the site, the central site of a lot of activity that involves reinforcement. But also the pain-blocking effect of heroin is complemented by the high that you get in heroin, cocaine, even some alcohol, so that you just feel better, but you do get a little bit of a buzz depending upon the drug. All that together are the origins of addiction.
Nick, would you mind chiming in on this?
Sure. I would take a kind of a complementary track. All problems really stem from a place of good intention. Opioids are painkillers. They are powerful painkillers. They work on a certain part of the brain, certain receptors in the brain called opioid receptors. The body has natural painkillers called endorphins that it uses to control the amount of pain feedback. But when I was first being trained in medical school, we were coming out of an era where most physicians didn't prescribe painkillers much. There was even a practice of not using painkillers in anyone who had abdominal pain, for fear that you might change the exam and the surgeons wouldn't be able to find out what they wanted. And I say that just so you understand that, the intent in the late 80s, early 90s was to try to make medicine a little more humane. And when we attempted to do that, a particular company that I emailed you about, came out with a new product, a long-acting opioid that allowed people to be treated for their chronic pain. Let's say you had cancer and you had a pain that couldn't be resolved, or you had a terrible arthritis in your back and it wouldn't go away. The idea was maybe we should be a little more aggressive with our pain control for the humanity's sake. Well, funny thing about opioids is that when those opioid receptors are stimulated, it changes the brain where behavior changes. And if you get enough exposure to opioids, people start to have behavior changes where they seek that medication again. And it doesn't take a lot. Apparently, in retrospect, it takes as little as 5 days exposure to opioids in a row to increase a person's risk for addiction. an addiction is really difficult to overcome. Once you have a desire, not a conscious thought in your head where, hey, you know what would be really great if I destroyed my life and I just, pursued these medications every day. People don't think that. But they act that way once exposed to opioids enough that they develop this addiction.
Wow.
And it's really hard to undo.
Yeah. Nick, I have to interrupt you for just a second. We have to go on our first break. You're listening to AARP, Arizona Hispanic Connection. The subject today, opioids, killing more than pain. We'll be back.
Welcome to AARP, Arizona Hispanic Connection. Educate. Celebrate. Connect. Arizona Hispanic Connection.
Thank you. Thank you for staying with us. This is AARP, Arizona Hispanic Connection. The subject today, opioids, killing more than pain. Opioids is supposed to kill pain, but it's now killing people. And this is a very serious issue. Representative Tony Navarrete, thank you again for being with us. General impression about this issue. Have you always been aware of this issue? Have you become more aware recently? Can you tell us your perspective about this?
Well, I think the issue around opioid addictions and overdoses and drug addiction has been around with us for a very long time, specifically around the opioids. And what's very interesting is that this is something that affects so many Arizonans across the state. It passes, different socioeconomic statuses, different races, ethnicities. It's just a very broad problem and crisis that we're facing in Arizona that we've been seeing. And we've been actually trying to push legislation through the Capitol for years. And it wasn't until this year that we started, really beginning to tackle the issue. But in terms of impressions, you're absolutely right. The opioid epidemic is killing people. And of course, I do want to separate those who have chronic pain because, those are individuals that need to be protected, including their pain management doctors. But the truth is that we have lots of individuals, and I think Nick said it earlier, the moment you give someone a 5-day prescription of opioids, they are more likely to become addicted. And that's a real issue. And we've seen since June 2017 to January 2018, we've seen over 800 people lose their lives in the state of Arizona.
Wow.
And over 400 babies born addicted to the opioids. So this is a real crisis, and I'm really, really thankful that you're bringing attention to this issue because I think it's an area that Arizona needs to be aware of, and that there's people that are, ready to help in the process of healing. But it's a real issue that's going to have a long-term impact here across the state, and also across the country.
And we'll come back to the legislation, the effort of that Governor Ducey, launched. My concept in the past was that perhaps somebody had a rough life. They started getting into drugs, and then all of a sudden, before they knew it, they were addicted, and they, some overdose. But this problem, what basically impressed me is that it doesn't necessarily, that's not necessarily the whole picture. You can have an athlete, you can have just a normal person have an accident, and then they go to the doctor and they prescribe this medication, and before they know it, they get addicted. So the picture that is, the person who had a bad experience, rough life, this and that, it just doesn't tell the whole story. This is a very serious issue. And again, I would like us to, Nick and Felipe, if you can educate us about the drugs that are used usually, currently for medications, because these names are so difficult even to pronounce. Can you shed light on just the names of drugs that are used for pain medications?
Well, OxyContin and fentanyl are two of the major ones, but there are several. The idea is that if people have the need to feel better so they can function daily, and when you're under chronic pain, you can't function well. Just think of getting a headache and it doesn't go away for weeks.
Right.
Even that, which is a natural occurrence, begins to take the edge off your ability to function normally because it's there all the time. And so after surgery or other things, people have chronic pain. So the issue is, how can you help people function normally as much as possible? And that's where medications come in. But it's absolutely the case that opiates are some of the most addictive substances simply because not only do you block the pain, but you also begin to feel better in other ways. Whether and for many of these, you get some type of a high, especially heroin. But beyond that, the issue is you function better. And so therefore there's a motivation to go back to it.
Right.
Now, as mentioned earlier, there are the process of addiction is literally a change in the function and structure of the receptors in the central nervous system. They adapt to the new substance, and therefore now, in quotes, the brain wants it. There's cravings. There's a desire, and that desire is biologically based, but also psychologically based. So addiction is a very fascinating.
So
and complex
psychologically and physiologically, you get this craving, if you will, for that
craving. And different drugs have different craving patterns. But the other thing which is important in the opiates, heroin being the classic example, is then you have a withdrawal syndrome, which means that if the body isn't getting it, that hunger, the craving, you're not feeding the body with the drug. Now there's a reaction,
right?
And some drugs you have very little, like with cocaine. It was thought not too long ago not to be addictive because you didn't have that withdrawal. It is addictive, but in another way.
Right.
So every drug has a different pattern. Heroin in particular, you have this withdrawal syndrome, and people are desperate to get it. The same actually with nicotine, tobacco. You have the withdrawal. You need to smoke again.
So you're describing the how addiction functions, if you will, and it can be applied to many substances, right?
To many drugs, and that's why many drugs are illegal, because they are at high risk for that pattern.
Right.
And the downside to that, in some of our work here in Phoenix too, with a variety, primarily it was methamphetamine and cocaine users, but some heroin users as well, is that it shifts the lifestyle. And there's a measure called the Addiction Severity Index, and you go through the different areas in lifestyle. Long story short, you have a downturn in medical, well, put another way, more medical problems, legal problems, social problems, family problems, psychological, psychiatric problems. It's a whole syndrome. So people that are addicted, their life has shifted towards high problem, high disease.
Wow.
And then, of course, you have crime that goes with it. They need to do something desperately to get that drug, and that involves stealing or all kinds of other illegal pursuits.
Right.
And then they wind up with legal problems, and so now they get into that arena. So you can see addiction is a very negative thing.
Definitely. Nick?
That's a very great description, an accurate description of of drug addiction. But what makes the opioid epidemic so difficult is that it is people from all walks of life.
Right.
Look, I mean, the opioid epidemic is also a little bit of a crime story. There's a particular company that manufactures long-acting opioids called Purdue Pharmaceuticals. They manufacture OxyContin and oxycodone, two types of opioids, one long-acting, one short-acting. And they were sort of part of this push. The push was larger than just them, but they were part of this push to try to treat pain more aggressively. And they marketed a product that they said OxyContin was less addictive than already established narcotics. And that turned out to not only be not true, but maybe even a lie. And our prescribing behaviors were changed significantly so that we started to use things like OxyContin and oxycodone much more liberally. And once exposed, people then formed a habit. And once we became aware of this, we've changed our prescribing habits. But the need is still there. And in order to fulfill that need, some people have turned to buying medications on the street or even using heroin. But from the 90s to the mid-2000s, across all of medicine, these medications were widely used to the great profit of Purdue. And it's not to say that doctors weren't involved, but we were making decisions based upon apparently erroneous evidence. And that's what's different about the epidemic than, say, traditional drug addictions, that it is all walks of life, whether people have their lives going well or poorly, whether they were raised right or raised wrong. It has nothing to do with their social economic or their social status, but everything to do with just the pure effect of opioids to change behavior.
Right, and this is what shocked me. You know, again, I have to repeat. The image I had was, okay, somebody has a rough life. They start using light drugs, and then they get heavier and heavier. But no, this is somebody who was perfectly fine. Maybe they had a surgery, and that's how the addiction was triggered.
Sure. Some of the early work by sociologists and others, there was a bit of that profile where certain communities, low income, would have people that are suffering, and that's where the drug trade came in, and they would get addicted to drugs. And so in the 50s and 60s, there's very interesting research that shows that there were communities and groups of people that began to have a culture of their own with the use of opiates, as heroin in particular was part of it. But that has changed radically now, and absolutely anybody can be, of any social class, any ethnicity, etc., can be affected. And I think the availability and the point well made that it was thought that this is a safe opiate. And so now physicians said, well, now we can help people. We can help them with their chronic pain, only to find out that that was an erroneous statement. Ultimately, now you have an epidemic. There are other regions, too, where the availability of these substances was much higher. And so we have a little connection in some of the work that we're doing in Ohio and Pennsylvania, and it's in the rural regions of people where they're unemployed, they're suffering, they need help, and they might also be unwittingly or otherwise part of the trade, the drug trade.
Wow.
So it's permeated. These are not people that are criminals, but when you have it there and you can share it with family and friends that are suffering, all of a sudden it proliferates.
Right.
And so now you've got it's both criminal activity, people that just need to help their friends or their family, that they themselves are suffering, and then they keep going for it more and more. So you can see how they can proliferate.
Right. We have to go on our second break. And here in Arizona, Governor Doug Ducey has an initiative regarding this. They understand that this is a big problem. And we have Representative Tony Navarrete, who obviously, as a legislator, is aware of these initiatives. And we're going to come back to him. But we have to go on this short break. Stay with us. This is AARP, Arizona Hispanic Connection.
Welcome to AARP, Arizona Hispanic Connection. Educate. Celebrate. Connect. Arizona Hispanic Connection.
Thank you for staying with us. This is AARP, Arizona Hispanic Connection. The subject today is opioids, killing more than pain. And as we know here in Arizona, Governor Doug Ducey started that initiative that I think is very, very important. And who better than Representative Tony Navarrete to share with us what that is about?
Yeah, so the Governor Doug Ducey has been approached with this issue, on countless occasions, and I think he knew that it was time to begin to address the issue of opioids in the state of Arizona. So from the beginning, Governor Doug Ducey really shared some leadership and really brought in the Democrats to also be part of this from an early process. So from the get-go, we were able to really bring a lot of our in-depth knowledge in the healthcare policy field so that we can begin to address the opioid issue in a bipartisan way that is reflective of Arizona and what the needs are. So we were able to work with lots of stakeholders across the state. And again, this is only a first step. We know that this Opioid Epidemic Act of 2018 isn't the final answer, but it's a first step to begin to address the crisis in the state of Arizona. Like I mentioned earlier, we have seen over 800 lives lost in a span of 6 months.
Wow.
Over 400 babies that have been born addicted. So what this bill does, it really breaks it down into many different levels. It doesn't go after pain management doctors and those who have chronic pain, but what it does do, it does allow those doctors to have the authorization to pursue different methods of pain treatment, whether that's naturopathic or other methods. There's a clause in there that allows individuals who have the drug on them, whether it's heroin, whether it's opioids, whether it's pills, anything. They can bring it to law enforcement, to a fire department, and they won't be scrutinized, but they'll be given information about what treatments are out there. There's provisions in this bill that allows for some immunity, because one of the things that we've seen in many occasions across the state is that there's an overdose, and because the other individual has paraphernalia on them, or they also have drugs on them, they will not call the cops. So we do have a provision in this bill, and it has a sunset date, so it will expire at some point. And what it does is that it gives some flexibility for the other individual to call the cops if they see one of their friends who is potentially overdosing, or a family member or spouse. One of the big things that was not part of this opioid act was a syringe needle exchange program. And that was the number one recommendation that we heard from stakeholders all across the state. So that was a big piece that is missing in this bill. However, just this week, we were able to pass a bill that would provide a needle exchange program and in the state of Arizona. So the nonprofits that are out there working in the streets, nonprofits that are out there in some of the exchange areas where folks are gathering to exchange drugs, they're going to be there exchanging dirty needles for clean needles, because we also have to be mindful of the impact of hepatitis C. We have to be mindful of the spread of HIV and AIDS. We have to be mindful of other diseases that are out there, and we want to reduce that cost for the taxpayers. So this allows us. This allows those groups to exchange without being held as criminals.
Right. Now, there is a drug that is used to counteract, if you will, the opioids addiction. Are you familiar with that concept? I believe there's also some provisions related to that drug.
That's correct.
The counteracting agent is called naloxone.
There you
Naloxone,
go.
excuse me. Naloxone.
That's correct. So this provision does allow naloxone for folks to carry naloxone. So if there is, or these kits, because there's a lot of nonprofit organizations that have these kits, so they'll give them to some of the folks that are using. So if one of their family members or spouses or friends is having an overdose, they already have those kits available. So it does give a lot more access for the use of naloxone in those cases.
Right. Since we touch on this names, these drug names are so difficult to pronounce. I have it here as naltrexone.
The generic form is naltrexone, and the brand is naloxone. So naltrexone is the generic form.
Can you help us understand how this process of counteracting the addiction works, especially as it relates to this drug?
It doesn't counteract addiction. It counteracts the effects of opioids.
Okay.
So the problem with opioid is that when people get too much, they stop breathing. And that's how people end up dying. If they become attenuated to opioids and have to use more to get the high, one of the side effects is respiratory depression. And if they stop breathing, they will suffocate. They'll be so sedated that they suffocate right there. That's how most deaths occur. Naloxone will reverse the effects and allow the body to do its normal work of trying to keep itself alive and start breathing again. But as far as the addiction goes, that's a hard thing to reverse, and we don't have a drug that reverses it. We have drugs that will temporize it. There are other medications called Suboxone that people can take daily, or methadone that they can take daily, that act as an opioid agonist without the high.
Right.
They work that way, but it's hard to get them because they're highly controlled, and you have to be part of a program. And just imagine I want you to imagine a mom, because I met this lady, a mom who makes her daily experience, her daily work to try to figure out where am I going to get opioids and which pharmacy am I going to buy them from. and then turn around and say, look, we've got a fix, all right, but you got to show up for methadone every day at 5 o'clock. That's kind of the battle that we're having, is trying to get people to take ownership, of their own health is one thing, but trying to get addicts to do what's in their best interest in the long run, that's a whole nother challenge that I suppose your other panel members could talk about.
Yeah, and one of the big wins in this legislation is that we were able to get in there because most of the language was really about preventative efforts, really about how do we handle not allowing so much opioids out in the market or out in the public. So we were able to negotiate a $10 million funding pool for addiction treatment, and what it covers, it doesn't cover folks with access. It covers those folks that are either underinsured or uninsured across the state of Arizona. So there is a $10 million fund to provide some of these services for those who are looking for recovery. Right. And that's a huge win because, like I said, we were just focused on preventative measures, but we have to deal with the issue. And we still have lots of individuals across the state of Arizona and quite frankly across the country who are addicted and really need that specialized treatment to become healed.
Right. In the information, as I did a little bit of reading on this, there are some sites online that offer great information. And in one of them, I saw a map. Arizona is a state that has a big problem in that map. When you see, how they color coded, it is coded in the darkest red, I believe they use to show what states are really being hit by this issue, and Arizona is one of them.
Yeah, it might be the highest prevalence rates, the number of cases that now have the problem. I wanted to follow up some of the points made, and I know best because that's where we were working with those that were provided with methadone as the substance to counter being addicted to heroin. And interesting things would happen because with methadone, you then don't have the pain, but then you don't get the high either. And there would be cases, quite a few, that would admit to us that, well, yeah, I kind of chip away, called chipping. I do the heroin too. And so they were going back and forth. Now, the goal was ultimately to titrate the methadone, so ultimately to wean them off, and now you don't have the addiction to heroin and you don't have to use methadone anymore. But that was really a challenge because people were either afraid or uncomfortable in not doing the methadone. And the other is going back to heroin. So it didn't quite help. And the issue, too, is if you don't get the methadone, then what? Then you go back to the heroin. And I remember lines of people waiting to get the so-called the juice bar, getting their fix of methadone. But it was problematic going there. And sometimes people just give up. They say, I'm just going to go back to heroin. At least I know what that does and I can get it. And the more availability, of course, the easier it is to stay on those drugs. So it's a really difficult cycle. And what I would just say to that is you need social support system. No one does it alone. Willpower is not going to do it. You need support. And I think also the legislation, I mean, it's understandable that it's a complex problem, but to punish people for their addiction is not really the ideal because it drives them underground and it creates more problems. And so there's a need to control and regulate, but not to punish. That's my view.
Yeah, and that's correct. And one of the things that I do want to mention, you mentioned the map, Arizona being a hot spot across the country. Right. And that's the truth. We approached this very late in the game, and now we're having to do all of these measures, have a special session. Now that we're seeing these numbers just quadruple, right? It's a real issue. And if you look at Mojave County, which is in western Arizona, it is one of the top 5 counties across the country. I read that is a high prevalence of HIV new contractions and hepatitis C, and that's because again, folks are using these old needles, they're sharing needles, and we need to, as legislators and policymakers, really be proactive in this issue. And this step one should have happened 3 or 4 years ago, but now we need to catch up, right? And that's what we're doing today,
right?
Oh, I was just going to say, I can't emphasize enough how this crisis requires different approach than traditionally we've taken with drug addictions. We can't imprison it away. We can't just tell people that they have a moral problem. It requires a very new set of skills for us to be able able to adapt to this complex problem, things that we have never really been willing to do before. But needle exchange, supervised injection facilities, all of these things are being tried across the country to try to just stop the death. We don't have the great answer, but we need to be willing to experiment to find it.
Do you think there is the right platforms to pursue that?
You know, I'm heartened by what's happened. We've become much more aware of it, so that helps, number one. But I think it's beyond just what happens in healthcare. Society and our regulatory bodies, our government, everyone needs to pull together to try to stop what appears to be a little bit of a runaway train. Non-pharmacologic pain management is an interesting option where we don't use opioids, but we try to help people deal with the presence of pain in their lives so that they become more accustomed to it or less reactive to it. That's one option, but once you get addicted to opioids, it's really difficult to get people to stop. We have some medications we could potentially use, but they require the DEA's license and permission. And currently, if you want to treat people, say, with Suboxone or methadone, you're limited on the number of clients you can take. I have a personal friend who's a physician who opened up an addiction clinic and filled it within a day. And at most, he can take 15 people. He filled it in a day.
Wow.
It's really difficult to, currently with the tools that we have, to address it. So I'm glad that the governor and the legislature are embracing new ways to tackle this crisis.
Yeah. Thank you, Nick. We have to go on our last break. Stay with us. This is AARP, Arizona Hispanic Connection. We'll be right back.
Welcome to AARP, Arizona Hispanic Connection. Educate. Celebrate. Connect. Arizona Hispanic Connection.
Thank you for staying with us. This is AARP, Arizona Hispanic Connection, with the subject today, opioids, killing more than pain. I really like this subject because it really illustrates what's going on, painkillers. And actually, I realized that when I did the commercial or the ad that I always do for the show, I separated painkiller. And then I realized painkiller is one word, but I left it like that because they're supposed to kill pain. But now it's killing the people that is supposed to help. So off the air, Felipe, you were saying about that this is a health from the health side of it, and then the or policy side. So kind of both have to be there and work together, correct?
Yes, I wanted to make the point that, of course, that's my orientation, but I think it's very important to take a public health approach. And public health basically says, let's make sure the community is safe. And so interventions, whether it was in the HIV days of having condoms more readily available to make sure you don't infect other people, needle exchange, which has been big in Europe, but here there are a variety of reasons why people are uncomfortable, but it is a public health approach to reduce the spread of anything that contaminates the lives of people. So from that standpoint, there is a need to consider, and I believe in a public health approach, which says if something works and it's been scientifically shown to work, which is the other part of it, we need science-oriented approaches, but also approaches that are culturally relevant to the local community, all that together. And it means a team approach, that there are stakeholders, you bring them together, and you find something that works in the local community. It may not work in another region of the state or the country because communities differ. But you want the science that tells you this is what works best at this point, and try to implement it in the community that you have in ways that works in your community. That combination is, I think, the general strategy, and then the specifics depend on the particular problem. But that's important because these epidemics are epidemics that are not going to go away on their own. the forces that created them are still in effect. Part of it is regulation, legislation to change those forces. Others are the medical, which helps people with medication. And I would say the other is psychological. Not only should medication be prescribed, but ideally, but not all the time, counseling, therapy, those kinds of human psychological issues that are also important.
At what point counseling, psychology intercepts this whole scenario? Is that when somebody's already addicted, when they're prescribed the medication for the first time?
Good point. Yeah. Well, I think there's the prevention side, where, like drug education in the schools, we've been working in that area, and it's sad to say that it doesn't really get the attention it needs, and it should. We need to bring it back. That's the prevention side. So in middle schools and high school, kids know what they're up against. But then some kids have major problems, and so they need more intense counseling. In many ways, the past, there was a lot more focus on those kinds of treatments, both medical and psychological, for drug issues. Many of that much of that funding has gone away for the prevention side. We must bring it back. But then there's the treatment side too. Once someone is addicted, they need special help because, as Nick mentioned before, it's not easy to kick an addiction. Even tobacco, it's really hard.
Right.
And so you need that social support system. It's not cheap, but on the other hand, the price of not doing it is greater. Deaths.
Right.
For example, CDC reports 42,000 people died in 2016 from heroin and opiate prescription drug overdoses.
Right.
And so those are the kinds of costs that need to be balanced by providing these investment in those resources that can prevent or treat effectively.
Right. So now we've moved into the solution or possible solutions for this issue. You're talking about from the public health perspective, from the legislative perspective, from the psychological perspective. This is a huge problem, and how do you see this moving forward in terms of making progress?
Well, I think throughout the country and in communities, folks need to pay more attention to this issue, although there's so many that we need to be concerned about. But this one is starting to get out of control. And in fact, the hallmark of addiction is loss of control. So when people are addicted, they're not in control of their lives anymore. The drug is controlling them.
Okay.
And so there's a need to do something about it, because the last thing you want in any activity is to be out of control. Whether you're driving a car and you can't steer it anymore, or whether you have an addiction and you can't control it anymore. So when those things happen, it becomes a big risk for not only the person, but for those around them.
Right. And one of the things that impressed me very much is I typed the two words that to me were striking is euphoria and pain. So drugs have this kind of dual effect, right? They're supposed to kill the pain, and you want that.
Yes.
But then they also produce a kind of euphoria, which we can also call it a high.
Yes.
So that's why it's a little tricky here.
Yes, and I'm glad you brought that up, because the drugs of abuse have that euphoria in one form or another. And that's why they're so alluring. I remember at least one, but I think it's been more than one in the past, interviewing. We've interviewed dozens of drug users in our prior study. And on occasion, you would have a heroin user, and the question is, do you remember the first time you used heroin? What was it like? And there were variants of this, but the person would say, the first time I used heroin, I fell in love.
Wow.
I fell in love. It was like a breakthrough. And I think the issue is that people are suffering, whether just with pain, but also psychologically. They're depressed. They have a disorder, bipolar disorder. They have some with schizophrenia. And so they have major psychiatric or other problems. And then this seems to be, it's like the cloudy day disappeared. I've discovered something that makes me feel good. And now it's hard to go away from it. And so they see it. But the issue with many drugs, more use changes the function of the midbrain. And so you need more to get the same high, more to get the same high. And that's part of the profile of many drugs. And so then you're hooked, and you must have it, because now the withdrawal is the chaser that people then start saying, now I have to have it. I've interviewed also alcoholics and others, people with alcohol problems, and they want to stop. And I've heard many people that have said to me, I don't want this anymore. But then the next day they go back.
Right.
Because they're not in control. Part of their brains, I say it's a battle not between right and left brain, but upper and lower brain. The upper brain says, this is crazy, don't do this anymore.
Right.
And the person believes it, and when they're talking to you at the moment, they want to get rid of it. But then the midbrain says, no, give me that drug now.
Right.
And so it's the battle between these two parts of the brain, the upper, the logical and the thinking brain, and the biological brain that says, I'm hungry, give it to me.
Yeah.
And so that's where a lot of support is necessary because you cannot do it alone.
Yeah. And you know, we did a radio show recently on nutrition, and just the education that I get just from hosting these shows helped me in making changes in my daily eating habits. So I am a strong believer in education. If we get educated a little bit more, you know, in that video, and actually I think it's called Hooked, the video that I referenced earlier that Cronkite News website has, is called Hooked. And in the end, a lady says, if I had just gotten a little bit more information and education about prescription drugs. And again, sometimes when we think of prescription drugs, we think, oh, they're safe, the doctor's giving it to me, nothing's going to happen. But I think as consumers, we also have to be educated even on prescription drugs to see the potential for addiction.
It really is an addiction. The other thing is, I don't think I've ever interviewed a drug user, drug addict, if you will, that said, I started doing drugs because I want to be addicted. Because the opposite replies the case. Early on, they say, it's not going to happen to me.
Right.
I can do it.
Right.
And then they enjoy it, and I'm still in control.
Right.
And then the next thing you know, it sneaks up on them, and they're out of control. And then now they have to resort in desperate attempts to get that drug, to get their fix.
Right.
So those are the kinds of things that we need to educate adolescents with. The other thing is adolescents' brain is not fully developed, so they have conceptions of life that are a little different, and they don't think they're ever going to die.
Right.
I mean, somebody who's 15 and you say, well, you could really die, you know, before 50. Well, that's lots of lifetimes in the future. So they say, I don't have to worry about that now. But, you know, life happens. So these are the kinds of things we need to orient our young adults and adolescents to be aware of these and to say, well, I may not understand it, but the people that I trust are telling me, don't go there.
Right.
Because you're going to suffer. And when they see others, the other is peers that tell them, those that have already been affected, and they say, I thought I was going to survive it. I didn't. Look what happened to me.
Right.
And that's a powerful peer. Testimonials and statements are powerful. But we also need to bring the science in because there are misconceptions about what does and doesn't work.
Right. Life is complicated. There's a lot of moving parts in a society of 320 plus million people, at least here in America, and we desperately need to take measures to educate ourselves, to really understand how things work, the functions of eating, the functions of prescription drugs, and other kinds of medications. And we will continue to address these issues. I really want to thank you, Dr. Felipe Gonzalez Castro, for your time and expertise. Thank you so very much.
You're very welcome.
Yes. And I also want to thank medical doctor Nick Vasquez, who joined us. He worked late yesterday. He has to work today again. So thank you so very much. And to also Tony Navarrete, representative of Arizona here. So thank you so very much. We really trust that this was a helpful subject, and we will continue to address subjects like this. Stay tuned. This was AARP Arizona Hispanic Connection. Have a great week.